The Joint Committee from Health and Welfare, both the Senate and the House, are represented today. Representative Wood is the chairman of the Health and Welfare Committee in the House, and I'm Lee Hyder. I'm the chairman of Health and Welfare Committee in the Senate. And many of the members of our committees are represented. Some may have to leave at various times throughout the meeting. It doesn't mean that they're uninterested. It just means that they have other commitments. But we certainly appreciate all of you making the effort to come here at such an early hour in the morning. You're wonderful people. We recognize you have issues, and I talked to one gentleman who drove in last night, got here at midnight, and is up this morning and ready to go. And we certainly appreciate all of your effort in coming here, helping us as Health and Welfare Committee members to understand the issues that you're facing in the medical field and the plight that you have. And that's why we've convened this hearing this morning. We would ask that each of you take no more than 3 minutes to explain the issues that you feel are important for us to hear. There are more people by far than we will be able to listen to in an hour and a half. We have scheduled from 8 o'clock to 9:30 this morning to be able to visit with you. And so we're going to ask those of you to come up 5 at a time and sit in these 5 seats over here. I'm going to ask first off for Ian, James, I think it's Bott, Kathy Mercer, Bobby Phillips, Rachel Rao, and Glenn Rao. So if the 5 of you would come up, and you'll be our first 5 that we hear from. You'll notice there's a timer on the bench in front of you, and we will go strict time periods of 3 minutes. You'll receive a 1-minute notification, and we will probably cut you off at the 3-minute time if you're not completed. So try to wrap it up in time to be completed by that time. So Ian, you're first, and thank you. When you come forward on the other side of the podium, Okay,
Hello.
Ian, state your name, please, and then proceed with your testimony.
I'm Ian Bott. I'm a 30-year-old college student who also happens to have autism, ADHD, and depression, and I'm here to talk about dental as somebody who is a member of the who has had dental resources cut due to Medicaid, and second of all, to help other people explain that it is something that needs to be rectified for other people. I had to pay dental out of pocket for a few times due to a lot of dental work that I've had, especially with the bridge and several other things that I've needed to have done. And I have also needed to get the and now that I'm on the waiver program, it's covered, but my concern is for the people who aren't on the waiver program, who need dental equally more or as much as I do. My family has had bad teeth health for a long time, and I think that there are so many families that need to cover dental that don't have as much money in the reserves. So I'm hoping that people who need dental coverage can help get it rectified and resolved. And I thank you all for being here. And I hope that with all the things that people come to testify, if there's more testimony in this, I hope that there will be a resolving help for wanting to have the dental be eventually restored fully. Thank you.
Thank you, Ian. Kath, yes.
Thank you, Mr. Chairman. For those in the audience, there is legislation making its way through the legislature at this point in time that will restore dental benefits to the pre-House Bill 260 effort. So again, that's going through the process, but I think I'm encouraged by that, and we should get that accomplished for you. Thank you very much.
And next is Kathy Mercer.
Good morning, Chairman and Committee. I am Kathy Mercer from Meridian, Idaho. I am the parent of a...
Can you pull the mic down a bit?
Okay.
Thank you, Kathy.
I'm the parent of a daughter who started her mental health struggles as a child, and I'm also now on the State Board of NAMI, Idaho. You all got to work together. We are at a major crossroad. This legislative session could mark a significant turning point for all the people with mental illness in Idaho. I hear lots of references to doing the people's business. I think improving access to health care is in the interest of all the people. There are an estimated 80,000 persons too poor to qualify for the new health exchange. And of course, 2/3 of these already are working at full-time, low-wage jobs, many at minimum wages. And with Idaho having the highest percentage in the nation of minimum wage jobs, prospects for major salary increases for these young people is slim. NAMI Idaho endorses Medicaid redesign as the most important change that the legislature could make to improve the mental health system in our state. If this were to be enacted, 96% of persons living with mental illness would be covered. In 2010, Idaho was 51st in mental health spending per capita. We can do better. We can. You have all seen the data from the governor's workforce showing the financial savings possible for the catastrophic and the county indigent funds. And yet there's a lot of argument that this should be passed up and the program left on the back burner. When Medicare Part D was instituted by the federal government, it wasn't perfect. At first, there was a large donut hole for medications, which in subsequent years had to be refined and altered. What we have is a huge sinkhole with 80,000 Idaho persons in it. I feel confident Director Armstrong's team could come up with some initial wording for measures on personal accountability. These could be refined in the next session to further incentivize healthy behaviors and less usage of the emergency room based on data collected. But why leave so many people floundering until a perfect version can be tweaked? Wouldn't it be wonderful to sit here in 2015 and report that the catastrophic fund had $20 million left over that it hadn't had to use, instead of coming back and asking for further funding? The conversation this year has been about the community crisis centers. Again, we're catching people in crisis just before they go over Niagara Falls. Why not also put in place a system that would provide treatment earlier, before mental illness causes the person's life to disintegrate so seriously? Support and recovery services would again be available at the community level. With better health outcomes for both physical and mental conditions, we might actually see a decrease in involuntary commitments, which are at an all-time high. In closing, the business community supports Medicaid expansion, and the medical community has been in favor as well. NAMI Idaho and the parents of young people making poor wages encourage you to allow this important improvement get out of committee this year for discussion and debate on the floor. Thank you for your time. Thank you for your service.
Thank you, Kathy.
Okay.
Bobby? Welcome to the committee, Bobby.
Good morning. Forgive me, I'm a little nervous. I'm here as a parent. I've got 3 daughters, all diagnosed with bipolar and PTSD. I have, over the years, been their greatest advocate. First time I've ever had to face you guys. My youngest daughter, 13 years old, right now, we are fighting for the last 7 months to get a prior authorization through Medicaid for a medication that is actually finally working with this child and her disorder. Without this medication, this child has been in the court systems, been on probation, hospitalized numerous times, even at state hospital because of her disorder. This medication called Latuda, we have been fighting for 7 months. I've had to pay out of pocket when the doctor was not able to give us samples. These are $28 a pill. We can't afford it, you know? As everyday Americans, we can't afford that kind of prescription. All I'm asking is that the committee considers making it easier for parents to get the prior authorizations for the medications that our children really do need. And I thank you for your time today.
Thank you very much, Bobby. Rachel? Welcome, Rachel.
Hi. Chairman Hyder and Wood and members of the committee. My name is Rachel Rowie. I currently live in District 17, but I have lived in Districts 10, 11, 12, and 13 also. I live on a disability retirement income and Social Security disability. I was a petroleum engineer for the IRS in Washington, D.C., auditing the mainly credits on some of the top oil and gas companies. I kept my federal employee medical insurance, and I also have Medicare. I pay monthly for both insurances, but most of my medical expenses are covered 100% between the two insurances. I'm very fortunate. My medical expenses are close to $100,000 a year in the years that I don't have a surgery. My medications alone are valued at $50,000 a year. What does someone like me with high medical expenses do if they don't have health insurance? What about those living under the federal poverty rate and don't qualify for the health exchange? What do? Suffer in pain, crumpled up in bed, die? Medical coverage is a human right. Please consider expanding Medicaid, redesigning it. Thank you.
Thank you very much. And next is Glenn.
Oh yeah, let me just drop mine all over the floor here.
You're among friends, Glenn, so it's all right.
Sorry about that, you know, got to be a little klutzy when you start off in the mornings. Well, gentlemen and ladies, my name is Angel Rowie, or Glenn, as my life lives. I currently run a small business in District 17. A big way to save on prison expenses to expand Medicaid. Inmates would be covered under Medicaid, and that expense would be paid with mostly federal funds. The reason why I tell you this is I once was an inmate. I had stage 4 Hodgkin's lymphoma, which came back aggressively 3 times before I had a stem cell transplant. And the only one, and with all the high stem cell transplant, that alone cost the state over $750,000. Between all of my medical bills, it was about $2.5 million to bring me back to being cancer-free. I wasn't the only one with high medical expenses in prison. It would make sense to expand Medicaid to save the state of Idaho a little bit of money. Thank you.
Thank you very much. We'd next like to hear from Van Beecher and Tracy Warren, Sydney Jablonski, Colleen Fellows, and Carol Dixon. Are those persons still here? Okay, well, okay, would you stand up and, are you? You're Van?
I am Van Beechler, yes.
Thank you. Welcome.
Thank you. Thanks, Chairman and committee members. My name is Van Beechler. I am Clinical Supervisor for Developmental Disabilities Agency, serving Region 3 and 4. I'm here on behalf of the Idaho Association of Developmental Disabilities Agencies to testify on the children's redesign that was fully implemented July 1st, 2013. There have been many benefits to the Children's Services redesign since its implementation last July, and I'm sure you've heard a lot of positive feedback. I'm here to talk to you about some of the challenges that families and providers are facing with the redesign. I'll just go through it really quick. First, we'd like to address crisis intervention services. It's one of the services that are available with the redesign. It's a service for families whose children a service for families, children whose needs go beyond what traditional services provide. Currently, according to IDAPA code, crisis intervention can be performed by only a master's level clinician or a habilitative support level technician, which is a high school level education and a certificate from the state. Master's level clinicians capable of providing the service in-home are hard to come by, and the HAB support level technicians don't have the skills necessary to effectively intervene. We would like to see an intermediate level professional with a bachelor's degree, like the habilitative interventionist, to be capable of providing the service. Next, wanted to talk about case management. In Region 3 and 4, it has been going fairly well, especially with Easter Seals Goodwill providing services in addition to the department's case managers. But other regions, 1, 2, 5, 6, and 7 are reporting a lot of pitfalls because it's just the department case managers covering the caseload. Agencies and families are reporting the case managers that are overloaded, resulting in untimely turnaround on approval of services and lack of availability of knowledgeable staff. So that's a concern for us. We're also seeing accessibility issues in rural areas. There are not a lot of professional habilitative interventionist staff to cover all the services being approved on the plan of services. HI professionals are leaving the field because most services provided after school hours and on weekends, and there are time limitations when services can be provided, making it difficult to have a full-time caseload. Also, the amount of habilitative interventionists certified to provide services in the state is inconsistent with amounts that are actually providing these services. For example, as clinical supervisor, I have to have the HI certification, but I don't carry a caseload. So the numbers aren't consistent with people that are actually working in the field. We're also finding that there are inconsistencies in certification approval from the department for HI. To get certified, staff have to submit proof in the field for 1 year's supervised experience, along with transcripts, course descriptions, and syllabi proving that they meet IDAPA code requirements to become certified. We found that some staff with the same coursework and similar experience get approved and others do not, with no real rhyme or reason. This is also contributing to the shortfall of qualified professionals. Lastly, we're experiencing difficulties with the EPSDT process and the requirement to have a functional behavior assessment conducted by a board-certified behavioral analyst or psychologist within 90 days. This is such a specific qualification that it is limiting access to children whose needs go beyond what traditional services and what their budget tier can provide. Thank you for your
Van.
time.
We appreciate you, Van. Thank you.
Thanks.
And Tracy?